All right, what's up? Good morning, everybody. Good to see you. So we're gonna mix up Tuesdays a little bit. I'm jumping in for Morgan, who's out of town right now. So we're gonna chat a little bit of Thursday content on Tuesday, and then we'll have Morgan swing back around and jump back in on Thursday. So good to see everybody this morning. What I really want to jump into today is talking about harm, risk and benefit. This comes up a lot for me, so I spend a fair deal of my professional life talking about the risk or lack thereof of cervical spine thrust manipulation. Hey, what's up, man? Good to see you. It's a labor of love, right? Don't make me sound like it's a chore. It's a favorite topic of mine. I think it's an important one. Certainly our patients deserve for us to do our due diligence, and I just overall find the topic fascinating. But certainly I do run into a lot of apprehension with folks dealing with cervical manipulation, but this topic is much broader than that, right? I think there's so many areas where we as conservative rehabilitation specialists undertreat and underdose our patients. And I think oftentimes the results of that are very harmful. We as a profession are very prone to focusing on this concept or idea of doing too much to somebody and injuring them. Now, do not mishear me. Of course that can happen. But I would argue that we have put almost a fanatical focus on that side of the coin, when the reality is this idea or concept of doing no harm, that coin has two equal sides. And what we don't consider enough is the undertreatment side. And that's where, at least in my travels, in my experience, I would argue we see more harm to patients from an undertreatment perspective than we do from an overtreatment perspective, right? So let me give you the three big examples that I see all the time, right? And the first one is indeed underutilization of thrust manipulation, right? This is not to say that thrust manipulation is for everybody. It's not even to say that thrust manipulation is for a huge percentage of people. What I would argue is the overall trend of the research suggests there are some people that have mechanical spine pain that respond well to thrust manipulation. And we all are aware of the John Childs article. It was John, Julianne, Tim, all back in 2006 in Manual Therapy Journal, when they looked back. This was in '06, but they were looking back at their 2004 validation study in Annals of Internal Medicine, where they evaluated whether there was risk in not providing manipulation. And it was a great perspective because, again, what we constantly hear is what is the risk of providing thrust manipulation, right? What we don't consider enough is what is the risk of not providing thrust manipulation, right? So if we think we have an individual in front of us who the evidence would suggest might benefit from thrust manipulation and we don't provide it, we withhold that intervention. What is the risk of that? And the findings were significant, right? They found that they had an 8-time greater risk of a worsening or an increasing of their disability at the 1 week time point following eval, in a 4-time or a 400% increase in a worsening of disability at the 1 month time point, right? So it was found that withholding manipulation in an individual that the evidence would suggest might benefit from it is actually harmful. So here's a great example of not doing enough, right? Not fully treating the person, causing harm. And I think that we need to be looking at that, because if we don't step up to the plate, we have the chance of causing harm. Okay? Option B, right? Think about dosing the older adult. Christina Previtt had a great PT on Ice, probably like maybe 6 weeks or 2 months ago, where she really laid out that Lift More trial, right? Where they talked about over in Australia, right? Heavy resistance training, right? For individuals, for postmenopausal women who had low bone mass, right? So here's kind of this classic subgroup of individuals who you might be apprehensive or concerned to load because they have low bone mineral density. What the trial found was that actually loading these individuals was both safe and effective. So heavy, slow resistance training, right, showing to be safe and effective in individuals who have, or postmenopausal women who have low bone mass, right? So look at the program. If you get a chance, either go back to Christina's Facebook Live or look that article up, right? The actual program is heavy squats, deadlifts, and jumping pull-ups. And on those pull-ups, they were trying to have these gals land in a way that was firm, right? So they were encouraging them not to have a soft landing, but to have a hard landing in order to stimulate some of that bone mineral density improvement. And that's exactly what we found. So we found good compliance in both groups, but we found that heavy resistance training in postmenopausal women with low bone mass to be effective and to be safe, right? Third, we tend to underdiagnose or undertreat a lot of tendinopathy. Right? So when I'm traveling around and mentoring in the clinic, right, I see a lot of people that are afraid to cause pain or discomfort in individuals who are dealing with tendinopathy, right? And when you look at the research, what it would suggest is it's okay to have a moderate level of discomfort while you're trying to stimulate that repair and really get that process going in the right direction, right? Oftentimes you'll read even 5 or 6 out of 10 pain during the exercise. Now you want to be really careful and monitor that 24-hour pattern following that actual dose administration. But during the technique, during the performance of the exercise, it's okay if those individuals experience a moderate level of pain. What we see is a lot of people shying away from that. So the patient's in pain and they're like, I just don't want to put them through that, or I don't think it's safe, when the exact opposite could not be more the case, right? We see folks walking around with diagnoses of, trochanteric bursitis, when what we know now is a lot of that is underlying tendinopathy. What it needs is load, not rest. What we need to do is challenge those tissues sufficiently to demand a repair response by the body, to demand a response that says, I need to make those tissues more robust. But to be able to do that, to create that kind of response in that cell cascade from mechanotransduction, mechanotherapy, right, we need to have that stimulus be sufficient. Sometimes, in order to have that stimulus be sufficient, that stimulus winds up being painful, right? But as long as the 24-hour pattern is advantageous, that's a great example of when you want someone to tolerate some of that discomfort for the overall long game. Right? These are all examples, right? Whether it's underutilization of spinal manipulation, whether it's underdosing individuals who have low bone mass, postmenopausal women with low bone mass, whether it's not allowing someone who has tendinopathy to experience some pain to demand that remodeling. These are all areas where we hold back when what we need to do is step assertively forward. We have to understand the science behind it. We have to trust our clinical reasoning and process and say, hey, this is an area, right, where the benefits outweigh the risk. Because in all of those different paradigms, we know the risk is very low. What I really want you to think about is the risk of failing. So if you underdose somebody, if you undertreat somebody, and they fail, and they wind up doing something that has higher levels of risk, right, and they wind up getting hurt because of that, that is ultimately on your initial underdose where the blame lies. It's because you did not step up and get the job done. The person had to seek out additional treatment or change their lifestyle in a way that was maladaptive. And whatever sequela come from that, that is ultimately on you, right? Think about someone who you fail to dose out properly, or you fail to give them a full comprehensive treatment because you're concerned about increasing their pain or some of the risks where you aren't well versed in, and that person fails conservative care. And they go on and they use opioid management for their pain. What are the sequela to that? They go on and have to do some surgery, right, to try to address their symptoms, right? What are the sequela to that? What are the sequela when someone who has long-term chronic non-radicular back pain has a lumbar fusion, right? How effective is that really? And what's the downstream effect? Guys, think even more broadly, not even getting into opioids and surgery. What if somebody simply chooses to stop being active? Right? What if you fail to help them feel better because you underdose them and they stop being active because of it? What are the long-term sequela for inactivity? Right? You don't need me to tell you that, right? What if we don't get the job done and someone decides to reduce their functional capacity and stop being active because their symptoms didn't go away, right? The sequela of long-term inactivity are enormous and many. Right. I'm just trying to bring some gravity to the point that for too long, our profession has constantly focused on hurting somebody with our intervention and is not focused nearly enough on somebody winding up going down an unfortunate path, right? Or in other words, hurting somebody by withholding sufficient intervention, right? Think about that do no harm coin in the clinic and realize it has two sides. Yes, you can do too much to somebody and injure them. With the things that we do in the clinic and the evidence support that we have, right, our interventions are extraordinarily low risk. The odds are far greater that we are going to do not enough to somebody and injure them. Think about that in the clinic and let me know how it plays out. Lots going on at Ice World, guys. Ice Samplers coming up. It's all we can talk about right now. April 7th and 8th out in Las Vegas. We've got 20 plus people already signed up. I believe the room can fit almost 40, so I'm looking to pack them in. Would love to have all you guys out in Vegas. We have 9 of us that are going to be there, so we have 9 Ice faculty going all weekend. Every topic you can think of. A lot of great networking, a lot of great opportunities to connect. So hop on ptonice.com, check out the Ice Sampler. Other than that, everybody have a tremendous day. Enjoy clinic, and then look forward to seeing Morgan on Thursday. All right, do no harm. Both sides of the coin. Take care, guys.